Okay, now we're going to kind of put it all together and talk about heart-lung interactions. Ventilation is exercise, spontaneous breathing, that means. Spontaneous ventilation increases the amount of preload, intrathoracic blood volume, and also increases left ventricular afterload, and positive pressure of breathing does the exact opposite. If you know those things, you know the entire lecture. I'm just going to show you the clinical relevance of these. The biggest problem occurs with initiation of mechanical ventilation and with extubation. Breathing is exercise. A number of studies that have shown that breathing is exercise increases oxygen consumption using skeletal muscle exercise of the diaphragm and makes CO2 is too numerous to talk. I like the study by Zev Masinafar that said if you have heart failure and I have you breathe spontaneously, your gut will become ischemic. And then Amal Jabran showed that the arterial venous CO2 gradient fell. What Zev Masinafar did is he said, if I exercise a person with heart failure, their gut becomes ischemic. So why don't we wean them? So he took COPD patients and weaned them. And those that were successfully able to wean did not develop gut ischemia, here measured by gut pH. Whereas the patients who were subsequently going to fail not only had a lower value to begin with, but it fell to levels equal to severe shock. Amal Jabran then said, if this is the case, I should see the mixed venous oxygen saturation falling because the cardiac output will be inadequate to meet the needs. And that's exactly what she saw in patients who are weaning failures. Potentially the reason why all mechanical ventilation parameters used to predict who will wean or not from a ventilator are so terrible is that none of them take cardiovascular reserve into their determination. This is truly the big fish. If it is exercise, then it can be used as a cardiac stress test. And again, the number of studies that have shown that spontaneous breathing or extubation induces cardiovascular stress are too numerous to count. My favorite one is by Francois Lemaire. This is a copy of the original slide of his original presentation. And this is an example of one patient. And you can see the esophageal pressure here is around 4. The pulmonary occlusion pressure looks like it's around 18, 16, something like that. And then he places the patient on spontaneous breathing. The esophageal pressure at end expiration becomes more negative as the patient holds their lungs open. And there are massive negative swings in pleural pressure, down to minus 20 or 30. The pulmonary artery occlusion pressure rises to 40. And by 9 minutes, it's up to, I'm not sure why that does that. In 9 minutes, it's up to 50. And there's agonal respiration. And I asked Francois, what happened right here? And he said, I put the patient on the ventilator or they'd have died. Said in another way, it is not subtle. It's liberation from ventilation. So now that you accept that spontaneous breathing is exercise, now let's look at the causes of the mechanical interactions that have to do with changes in ventilation on the circulation and vice versa. But this is going to be the effects of ventilation, hemodynamic effects of ventilation. All forms of breathing change lung volume. They go up from functional residual capacity, and they change intrathoracic pressure. Both spontaneous and positive pressure breathing increase lung volume. But pleural pressure falls with spontaneous breathing and rises with positive pressure breathing. Thus, the hemodynamic effects that are different between spontaneous and positive pressure breathing are due to the changes in intrathoracic pressure and the energy necessary to create those changes. Under normal conditions, if we look at the lungs alone, if you have a spontaneous inspiration, you get vagal withdrawal and you get cardiac acceleration. And that's a nice way of showing that you've got normal autonomic tone. Also, as the lungs get bigger, they alter their vascular resistance. If you have hypoxia in the lungs, you get hypoxic pulmonary vasoconstriction, and that increases pulmonary vascular resistance. As the lung volumes get bigger, they are compressed, and autonomic tone is changed. So let's look first at the lung volume relative to where it is. The pulmonary vasculature can be thought of as being two types of vessels, the alveolar vessels and the extraalveolar vessels. The alveolar vessels sense those little capillaries. Their outside pressure is alveolar pressure, and all the other vessels in the lungs sense interstitial or pleural pressure as their outside pressure. And the difference between alveolar and pleural pressure is the transpulmonary pressure. It's the distending pressure of the lung. Thus, as your lungs get bigger, the transpulmonary pressure gets bigger. Okay. And so when we look at pulmonary vascular resistance versus lung volume, we see that at FRC, our resistance is the lowest it'll be, and that at low lung volumes and high lung volume, resistance rises. But the reason it rises is different depending on low or high lung volumes. Alveolar resistance is close to zero. They're just capillaries. But as the transpulmonary pressure gets bigger and bigger, as the lungs get bigger and bigger, if the transpulmonary pressure exceeds pulmonary artery pressure, the vessels are compressed and collapse, increasing pulmonary vascular resistance. The extraalveolar vessels at large lung volumes are held open, just like the airways are held open at large lung volumes. But as the lung collapses, as it gets smaller by the process of hypoxic pulmonary vasoconstriction, pulmonary vascular resistance increases. So, decreases in lung volume below FRC cause hypoxic pulmonary vasoconstriction. All forms of acute respiratory failure are associated with low lung volumes. Increases in lung volume above FRC collapse the alveolar vessels. All forms of COPD, respiratory failure, are associated with increases in lung volume. Hyperinflation in COPD is profoundly common, and as Marini and Pepe showed in their nice paper, if you just take a patient and remove them from the ventilator, when they're hyperinflated, their esophageal pressure will fall, as you can see, and the cardiac output rises from 2.6 to 4.7 because of the fact that the hyperinflation increases vascular resistance. Well, if this is true, then PEEP should recruit lung units, but if I have too much, it should hurt them. So Canada et al. Looked at pulmonary vascular resistance of lungs in which they caused one lung to be injured and the other not in a dog. And they progressively increased giving PEEP. And at baseline, the sick lung had a very high vascular resistance, which fell when the PEEP was added, 5, 10, and 15. This is almost assuredly hypoxic pulmonary vasoconstriction being reversed. The normal lung had no problems, and as you added more lung volume, its resistance rose. But look, there's nothing special about acute lung injury. Once both lungs have been opened, more PEEP increases pulmonary vascular resistance on all lungs. Finally, as the lung volume gets bigger, the chest wall can expand, the diaphragm can descend, but the heart is trapped in the cardiac fossa and gets smaller. That was nicely shown in this study, in which a CT scan was done on the same patient on ZEEP and on PEEP of 10. Look at how much the left ventricle volumes get smaller. That's just from increasing intrathoracic pressure. So now let's look at the effects of intrathoracic pressure on left ventricular function. Remember, increases and decreases in intrathoracic pressure will affect the pressure gradient for venous return and left ventricular ejection from the heart, independent of the heart itself. And you've seen this normal ventricular function curve, and Shelley showed you the venous return curve in his lecture. You and I have an equilibrium point. So you can see that with spontaneous breathing, as pleural pressure falls, CVP goes down, filling the ventricle more, and right ventricular stroke volume goes up. The opposite occurs with positive pressure breathing. So the CVP goes down, but the stroke volume goes up. I don't know what just happened here. This machine is funny. Okay. All I did was press return. So we said that the CVP went down and the stroke volume went up. CVP went down, the stroke volume went up. That's called spontaneous breathing. And this is without a change in function, and this is the reason why, this is the reason why spontaneous breathing has a higher cardiac output than apnea. And this was shown by me a few years ago, in which we measured the spontaneous breaths, and you can see that the right ventricular stroke volume went up a bit, but if you occluded the airway and had a really deep inspiration, you had a massive increase in right ventricular stroke volume. Loaded spontaneous inspiration occurs with cardiac insufficiency, It causes pulmonary edema. If you want to increase cardiac output in CPR after the chest compression's over, keep the airway occluded for half a second to allow the recoil to keep the pressure in the chest negative and release it, and you'll double cardiac output. Negative expiratory pressure also improves cardiac output in pigs with shock. What about positive pressure breathing? Well, the heart's in the chest, and so when I increase intrathoracic pressure, remember CVP went up and cardiac output went down. What we normally do is give them fluids. CVP goes up further, but our cardiac output's normal. This is why you fluid restrict a patient before extubation, because they're all going to have this increase in volume come back, as Francois Lemaire showed in his study. And in fact, Antoine Villard-Bras showed that what I showed in pigs was also, in dogs, was also true in humans. And furthermore, with Jamie Mosqueda, we showed that the greater the tidal volume that you had, the greater the amount of blood that leaves the chest, whether it be 5, 10, 15, or 25 ml tidal volumes. So now let's look at the other way. Increases in intrathoracic pressure, decreasing left ventricular afterload. And this is a really hard thing to explain, so I prefer to show you a picture of my children instead. This is Stephanie, Daniel, and Jill. They're swimming. Do you care how tall my kids are? Or how high their heads are above the water? It is the height of their heads above the water which is their transmural pressure. That might be their heights, but that's their transmural pressure. And thus, if I have a arterial pressure of 150 and I give phenylephrine infusion to make it 200, I've increased afterload to 200. But I can keep the arterial pressure at 150 and have an occluded airway and breathe into minus 50, and I have to go from minus 50 to 0 to 150, and that's the same increase in afterload. Negative swings in intrathoracic pressure increase afterload, and as we showed in 1979, when you do that, the right ventricle in a healthy person massively dilates up. This is the reason why negative swings in intrathoracic pressure causes pulmonary edema. This is why laryngeal spasm, airway obstruction kills you. You have the increase in venous return and the impediment to left ventricular ejection. Well, if that's true, if I make the pressure positive, although I'm going to decrease venous return, I might do the same as nitroprusside, decrease afterload. And so we showed that in an animal model, if you increase, with severe heart failure, if you increase intrathoracic pressure, intravascular volumes decrease because that's what they should do. It always goes down. But cardiac output actually goes up because you're decreasing afterload in heart failure. And we showed that in heart failure in humans. We could do it in a cardiac cycle specific way and could reverse mitral regurgitation. And this is the reason why PEEP has minimal effects, but if you're in heart failure, it'll actually increase cardiac output. Well, I can't give you positive pressure because it's too hard, but I can take away negative pressure. A person with airway obstruction or bronchospasm, if you intubate them or give them CPAP, abolishing the negative swings in intrathoracic pressure will equal adding positive pressure without any hurt on venous return. And the number of studies that have shown that using CPAP or BiPAP decreases cardiac stress are too numerous to count based exactly on that physiology. This is the reason why your first treatment for acute cardiogenic pulmonary edema is CPAP. And that was nicely shown by Radisson, who looked at it in patients who had acute myocardial infarction. He only got a benefit of the CPAP when the swings in negative intrathoracic pressure were abolished. And if you do that, you improve survival in acute cardiogenic pulmonary edema, both in a couple of hours and a couple of days. Look at the difference in mortality. And it doesn't matter if it's BiPAP or CPAP. It's not the inspiratory pressure that's helping you. It's the eliminating the negative swings in intrathoracic pressure. Thus, to summarize, as the work of breathing increases or cardiovascular reserve decreases, spontaneous ventilation may impose excessive metabolic demand on the heart and circulation, inducing shock and making the patient unable to be weaned. Said in another way, never try to wean a hemodynamically unstable patient. Failure to wean from mechanical ventilation often reflects impaired cardiovascular reserve. And abolishing negative swings in intrathoracic pressure markedly decreases negative afterload on the heart and helps it by decreasing ischemia. Thank you for your attention.
Thank you very much. You can have a seat here, Professor Magder. We'll have about 10 minutes or so for a couple of questions, or 5 minutes, following which we'll take a break until 5:30. No questions?
I was going to make a comment to Dr. Magder, and that is that I don't like the term systemic vascular resistance. Let me rephrase that. I hate the term systemic vascular resistance because there is no such thing as systemic vascular resistance. There's arteriolar resistance, and there's venous resistance, and they're not linear, and there's a vascular waterfall, which I'm going to describe tomorrow. I agree completely that resistance and flow are the determinants of pressure. But I don't think that we should be calculating systemic vascular resistance. I think we should be looking at the mean arterial pressure and the dynamic changes in pressure and flow. And tomorrow I'm going to go into that in great detail in my lecture. What do you think?
Well, thank you for that. But you're mixing up total peripheral resistance, which I didn't use, and systemic, which is basically the arterial. The patient on critical closing pressures or Starling pressures, and the periphery is actually my paper. It's the only one that documents that in that state. But it's still a phenomenon. If you know, whatever you want to call it, if the cardiac output is different, is the same, and the pressure is different, the downstream resistance has changed. It is all arterial. It stops at the arteriolar level. But I say SVR. I don't use TPR or whatever, total vascular resistance. I'll agree with you on that, though. It's to the arterioles. And and I actually noticed I put that funny little constant in. That constant is the critical closing pressure. It's not CVP. I didn't say CVP. If you notice, I wrote constant. No, I said SVR plus a constant, which is but I didn't get into the critical closing pressure. But that's what that constant represented.
Any comments, questions, remarks? Okay, we'll break until 17:30, and then we'll reconvene at that time. Thank you.
I wasn't supposed to present to you in this conference at all, but one day I walked into the office of Dr. Huda, as usual every morning, that I have to walk into her office to say hello. And she said to me, you're going to present a topic called tachypsychia. I didn't know what tachypsychia is about. I thought it's a Japanese dish or a Chinese noodles or something. And then I went to the usual Bible. It's called Wikipedia, Google, and I typed tachypsychia. And it's apparently something in martial art, but it's got a medical definition. So I said to myself, how can I talk about something that I don't know anything about? Well, it's very easy. You know, it's one of the things. I just tell you a story. And when I was a medical student, my doctor asked me to present in front of a camera about something that I don't know anything about. And I had to present about the camera itself that was in front of me because that's the only thing I had to think of. So I said to myself, probably I could do the same thing with you guys. I talk about something that you don't know anything about and I don't know anything about, and you're going to be so convinced that it's the right thing. But anyway, so I went and started to think, I'm going to do something that is going to be the introduction to a semi-education, which is simulation education. So let me just define tachypsychia for you. Tachypsychia is basically a neurological condition where the time perception is altered. Sometimes you're doing something and you find yourself, you spend so much time, but it's like a second. And some other times, you'll be standing there waiting for an event to happen, and the minute appears like an hour. That is the definition. But when it comes to with a neurological disorder, it becomes a disease. One of the factors that affect perception of time is stress. So I said to myself, instead of talking about tachypsychia, I'll talk about how do we behave if we were subjected to stress. Okay, So the thing that I'm going to present to you is something I learned. And how did I learn it? I learned it the hard way. This is how I learned it. I did a lot of mistakes, and that's how I learned. I wish I read about tachypsychia and about stress before I learned these things, but unfortunately, I did learn it the hard way. So I'll start with an incident that happened to me. About 2 months ago, I had an interview in Kuwait TV, where I was supposed to talk about pain management. And as usual, I was so relaxed. I went there. They called me and they said, your interview is going to be at 5 o'clock, but I had a case at 7 o'clock. I wasn't bothered at all. It was an interventional pain case at 7 o'clock. I said, I'll go at 5 o'clock. I finish the interview, and then I go to the case itself. I was so relaxed, happy, not thinking about my case after that at all. Not even crossing my mind. All I thought about is that I hope the hospital don't call me to come and do the case, so they don't interfere the interview. But you switch your phone off when you're on TV. So I finished, and it was a 50-year-old female, ASA2, diabetic and hypertensive. She was coming for a cervical facet block. For people who don't know, the facet is basically a joint that is between two vertebrae, and there is a sensory nerve, and we block that nerve in pain management when they have a problem with that joint. And she had posterior headache. She's coming to my clinic walking without any problems, and she's just complaining of the headache. And she had the classical presentation of C3 irritation. It's a very small nerve that crosses the articular process. And I said, it's a piece of cake. I'm doing this every day in Adan Hospital. I'm doing this every day in my private practice. It's the usual stuff. That's the block. You put dye, it's in the articular process, it's outside the epidural space without any problem. But she started to say, Doctor, my lips are funny. And I'm standing there. This is a normal subject who's lying on the bed, coming walking with her daughter and saying, my lips are funny, after injecting 1 cc of dye and 2 cc of local anesthetic. And then she started to say, I do not feel well. Something is wrong. And her eyes start to roll backwards, and she started to shut her eyes. So at that stage, her heart rate was 70. It went up to 150. And the blood pressure, I said to the nurse, I don't usually check the blood pressure because it's so quick. A procedure was so quick. I don't measure the blood pressure. So I asked the nurse, check the blood pressure for me, and it was 60. And I kept saying, wake up, wake up, wake up. She's not responding to me. And she was making funny noises. This is not her picture. This is a picture that I got from the internet. This is how she looked, basically. Her lips started to swell up. Her eyes started to become puffier. And she had a rash at the site of injection of the antibiotic. She had an antibiotic that was given while I was doing the procedure, and she had a rash across that arm. And they finished the whole antibiotic. So I said to myself, drill, anaphylaxis drill. I know this very well. I did that in the exam. I was reading it for my board exam. I was reading it for my fellowship. I know this very well. So let me go through the drill. But at the same time, this is what was going through my mind. Now, I have an untrained team around me. They don't know what's happening. They just realized that I am panicking, but they don't know what's happening. The nurses are not aware that the patient at this stage is really sick. I called for help. The other doctor was busy with a cesarean section on another floor. So they said, unfortunately, we cannot reach the other doctor. He's busy with a cesarean section on another floor. And I said to myself, good, that's all I wanted now. Now the third thing, she was beta blocked. So I'm thinking, if I give this woman adrenaline, is she going to respond? Is she going to get her pressure up? What am I going to do? All this is going through my mind. Should I intubate her? You saw how her face was. She was swollen up. And I'm thinking, is this going to get worse and I won't be able to intubate her? Should I intubate her now? Is she going to be a difficult intubation? And what medication would I use? She's already hypotensive. What if I give her the wrong medication? What if she drops her blood pressure more? What if I give her, I called for ketamine, there is no ketamine there in the hospital. All they have is propofol. All they have is propofol. Would I give her propofol and kill her? I don't know. I was so confused myself, and I'm looking around myself, and if you look at me, you will see that I'm panicking, but it's like being in a circle, going around yourself, turning around yourself, not knowing what to do. And I'm thinking what about if things happen in a bad way? What will I do? And I kept praying and praying that nothing could happen. What if we have to do a tracheostomy? What am I going to do? So many things that came into my mind at that stage, and I didn't know what to do. So I said to myself, let's go and let me recollect my thoughts and do what I can do at that stage. Believe me, in that situation, and I don't know if you were in that situation, but the nurses are running around and hitting each other, not knowing what to do. You'll say atropine, for example. You'll see 5 nurses going for atropine, leaving the patient. It's a chaotic situation. So, I recollected my thoughts, and this is what I did. I said to myself, I want to be focused. I want to do the right thing. So I took a deep breath in, I recollected all my thoughts, and I went through the anaphylactic drill step by step. I gave her 100% oxygen. I started communicating with the nurses on a basic level. You give fluid. You stay next to the medications. I want epinephrine. The technician, I said, do not touch the patient. You just get the drugs to the nurses. And I orchestrated a whole team on a basic level. I wish this works faster. So I gave all the medications, and then I was continuously praying, please God, stop me from harming this woman. Please. Honestly, that's what I was doing. I said, stop me from harming this woman, because I might do the wrong thing at that stage. And one thing that was going through my mind, what am I going to say to the family after this? So, let's talk about response to stress. This is the fascinating part about we as humans. So there are 2 types of stress. There's the psychological stress, which is a difficulty in performing a task, and there's the cognitive stress, which is a difficulty in making a decision. And whenever we're faced with a stressful situation, we go through the combination of stress, the psychological and the cognitive part. And the response to stress, we either fight or flight, or what do we do most of the time? We freeze. We don't know what to do. And if we freeze, the end result is probably catastrophic. And we all know from physiology, probably, there are so many hormones and neurotransmitters that are released in response to stress, and they have a role in your performance, and that's what we're going to talk about. It's very important that we know that the hormonal system is so much switched on in a stressful situation, and that's very important for your performance. There is a law that's called the Yerkes-Dodson law, and what it talks about is that if you are about to give anesthesia to somebody, and you're used to a routine way of giving anesthesia to somebody, and then something stressful happens to you, like this. The head of the department walks in, into that operating room, you start to have problems with conducting the usual way of anesthetic. And you might do a lot of mistakes that you wouldn't do usually. And it was found that whenever you are stressed, you either go through two phenomena. One, you can be so scattered in your thoughts and you switch into a default type of behavior, or you can be over-focused on something and you might overdo it. So, and they found also in animal studies, like the pipefish usually likes to mate with a large fish when it's the mating season. But if there was a predator around, they will go and mate with any fish. So it is a default situation that they go following in a stressful situation. The other thing that also they found, that if you are so trained in your brain to over-focus on something, you can so much direct your thought into such a tunneled vision, which might result in the wrong decision, which we're going to talk about later on. So to decide, to decide, it's a balance between the two. I have to skip through very quickly, because it's, and to get into the memory part, after a stressful situation, to have this memory built in your brain, it's the decision between the two. So if your default system is active, your memory is probably very strong. But if you're over-focused, that might not be the situation and might not stick in. And there's a lot of things that enhances the memory and reduces it. So this is the curve. And you can see performance or stress against performance. So in the red, you're sitting, you're relaxing. That's when I was doing the interview. And I have a low heart rate, I'm not alert, I'm sleeping actually in that interview. And then you move up and you get into the yellow range. And what happens? You get your best performance and your fine motor task becomes better, okay? And then after that, you get into the green zone. And in the green zone, what happens is that your heart rate increases and you lose your fine motor skill. And remember this, you see it all the time. When you want to put a central line, or for cardiologists, when they want to do a cath, and they want to slide the guide wire over the catheter, how many times you miss it? You lose the fine motor skill, but the gross motor skill is still there. So that's you're in the green zone in your performance. And then you move into the gray zone, where your cognitive problem, where your cognitive where your cognitive function becomes slow, and you start to have an over-focus and possibility difficulties in making a decision. And after that, you get into the red zone again, and that's where you don't want to be, which is the freeze type of behavior. So what I learned that I might not take in the right decision when I didn't intubate that woman. I tell you the truth. I was saved by somebody called God in that situation. I should have had intubated that patient. If you go through the drill, you would have gone through intubation of that. But I didn't intubate that patient. You know why? Because of my mental map. If you have, for example, a book that's of a color, blue color, and you know that book of blue color responds to the ICU book, and you want to look for it in your room and you put it somewhere. You go around looking for a blue colored book. But if you have it in your mental map that book is red, you can spend all day looking for that book and you wouldn't find it. And that's what I had in my mental brain. I didn't want to accept the fact that I had to intubate this. I was going around in my mental brain how to avoid intubation rather than to go and intubate that patient. And that's the same situation again. It's very difficult to take that decision and do the intubation. So who are the people who do not make the correct decision in these situations? You'll be surprised. Okay? Those people who do not update their mental map, those people who do not have the other options in their mental map of dealing with a situation. And not only those people, they are not present or aware of a situation. If you've never been in an anaphylaxis, You're not aware of it. Or if you've never been, if you haven't been told about anaphylaxis, you're not aware of it. And if you've never been in it, you don't know how it looks like. And not only that, most experienced doctors, you'll be surprised. You know why most experienced doctors? All of you do anesthesia. You walk into the room, what do you have in your mind? You're going to give propofol, you're going to put a mask, you're going to put propofol, fentanyl, rocuronium, intubate, talk with the surgeon, play with your WhatsApp, send a little bit of tweets, wake up, give reversal, and that's it. That's your experience every day for the last 30 years. You've never been into a situation where you have problems. And if you run into problem, then that's when you fall. Unlike somebody who's still updating his mental map all the time. Okay? So what do we need to do to avoid catastrophe? Have a simple updated mental map, reevaluate the situation, and think out loud. And that's what I did only one thing, which is I thought out loud in front of the nurses with that situation. And again, remember, in this situation, your frontal part of the brain is not controlling your actions. So your actions are independent of your frontal part, which tells you what is the right thing and what is the wrong thing. So the chances of doing the wrong thing is very high compared to doing the right thing. I did the wrong thing, and I managed to get away with it, by the way. I could have done the right thing and not get away with it. But it's good that I did the wrong thing and got away with it. Okay? So, where do I want to be in a stressful situation? I want to be in that green part. And we can play with this curve. I can make it higher, and I can make it wider. And how do I do that? It's by a process called stress inoculation, or desensitization. Desensitize yourself with stress. So how do you do stress inoculation? You need preparation and you need reaction. Two things that you need to do. In preparation, you need education, rehearsal, and application. Now, education is what we get through our board, and knowledge, that's in the textbook. And you need to have a simple algorithm. The rehearsal is what we're going to spend the rest of the night talking about and going through, which is the simulation. And you need a mental rehearsal. Even if you're sitting next to a patient that's going so smooth, go through your mental map and try to update it by going through a difficult situation. I'm going to give epinephrine, I'm going to do this, I'm going to do this, I'm going to do this, I'm going to intubate, I'm going to do tracheostomy, I'll do a midline incision, go through. And that has been shown in research, it has almost the same effect as if you're doing simulation. So have your mental rehearsal. Application, again, when you see this patient, don't do like what I do. I'll say to Dr. Ahmed Ali, go and intubate this patient or do this case. You go yourself and take the challenge. Put yourself in that stressful situation. Go through the difficult intubation. Go through the difficult circumstances. And the reaction, take a deep breath, make sure that you're calm and relaxed, and you want to get yourself to the peak of the performance, and talk loudly. This is what my daughter tells me when I speak to her and she doesn't like what I say. Talk to the hand, and she walks away. Okay? And think loudly, and don't do this. Thank you.
Bismillahirrahmanirrahim. Thank you very much, Dr. Hoda, for the kind introduction. And also thanks for the invitation to be back to Kuwait. It's very hard to follow Dr. Muhammad, and also it's very hard to talk at the end of the day, but that's the best combination, working in education and simulation. So if you're asleep after this is part of anesthesia. If you're awake, that's part of the education. So feel free to do any way you do. So I do work in different capacity with those people or these organizations, but none of them pay me money to say what I will say. So whatever I will say in the coming few minutes is what I believe in. I'm sharing the simulation center at King Abdulaziz University in Jeddah. We're located in the 4th floor, and everything I will say and talk about in the coming few minutes, it's things that I do with those great people, my team at the Clinical Skills Center at King Abdulaziz University. We do have a facility for examination, assessment, and training. We train all type of basic skills, all type of part tasks. We have a very active high fidelity simulation program. We offer courses in Saudi Arabia and GCC country, basic to advanced courses. Those are the numbers of sessions we've done for undergraduate education for the last 7 years. Last year, we celebrated completion of 1 million teaching hour for undergraduate students by using simulation. And of course, we throw a party. We freeze at that time, and just recently we got accredited by the Royal College of Canada and the Society for Simulation in Healthcare in all standard just 2 weeks ago. So as Muhammad said, I mean, there's increased public awareness about quality, increased education demands, medical practice is stressful, unpredictable, and there's simulation centers everywhere. Just to remind you, as anesthesiologists, we leading patient safety. Helsinki Declaration signed 3 years ago by the European Board of Anesthesia, endorsed by the WHO, focused that anesthesiology is leading. Patient education and education is key leading why anesthesiology is safe. We have lots of things to do, and no ethical or legal requirements could deter us from improving. And this is to promote that anesthesiologists are the leading in patient safety. This is when we talk to other professions, but when we look back in anesthesia, there is large room for improvements because we know that death is very rare, but still we do have a lot of cases of lots of unexpected outcomes like dural tap, dental injury, nausea, vomiting, difficult intubation, cardiac arrest. There is room to improve. And it doesn't matter where you look at the data, deficient teamwork and communication, leadership, human errors still contribute. As Dr. Muhammad said, we're just humans, we make errors. If we look at industries, high risk, low risk, this is climbing a mountain. That's very unsafe. Aviation is on the safe, ultra safe. Anesthesiology is safe, but general medical practice still unsafe. So we have areas to improve, and we could lead other professions to improve patient safety. Simulation is one. Of course, if you're successful, everybody, if you fail at that time or any time, you will have all of your friends doing this. So I will be talking about expanding role of simulation, familiar affairs techniques, how you could do it, how the way we do it, ways to increase practice of simulation-based education or reflection, as Dr. Muhammad said, without simulation, and reflect on some of the evidence. Of course, clinical competence talks about performance, how to use the skills when you need it. The problem with clinical competence, it's very highly case specific. So if you're competent in one thing, that does not mean make you competent in other things. That's why the goals of education and in medical practice, always we talk about knowledge, skills, and attitudes. For each of these, there is 3 levels: knowledge, application, problem solving. If you look at most of the teaching is focusing on recalling and comprehension, but we ought to be focused on applying, practicing, valuing, the hand-on training and assessment. Other way of looking at this is the Miller triangle. We know a lot of things. We know how to use the information, show how, and then does. If there is a higher level of performance in real life or assessment, simulation come at a higher level. If you do a board exam, oral exam, you could just test to know how. But simulation and real patient, standardized patient, real practice, those are the people who could, this is the technique that will function at the performance level rather than the, so I will not spend a lot of time talking about these things, just, definition. The simulation is a technique rather than technology. So it is not the technology that matters, it is actually how you use it to invoke education. Why use simulation? Of course, see one, do one is becoming less acceptable, especially for high-risk procedures. And there, we have to find alternatives. I don't know what's the problem what's the situation in Kuwait, but in Saudi Arabia we have increased maybe 300% in medical students and residencies, and we have to find different ways to teach the students. Of course, it makes more money to work on clinical than to teach. Patients don't stay in hospital very long time. They're sicker. We can't train on them. Some procedures we can't teach effectively. Either you could see or the students, like airway manipulation, cardioversion, you just can't teach that for medical students and residents, and medication administration. Just give adrenaline and see the effect. Simulation make, of course, loss of resistance. A lot of things are very sensitive. Pelvic exam, breast exam, you just can't teach everything in patients. Of course, there are few things that are very rare. So how could you maintain competence over, even for ourselves or our students, to make sure everybody is competent to do that rare things when happen? So there is never a risk to the patient.